Hi, welcome back to UWorld's Next Gen NCLEX Review. My name is Samantha and I am a nurse here at UWorld. Today we are officially in October. It is October 1st, which means that spooky season is upon us, and I think we have a pretty spooky topic today, and that is traumatic brain injury, or TBI. This is one of the leading causes of death in both adults and children, and many of you watching today may have suffered from a TBI, may know someone who has suffered from a TBI, so I think this is some very relevant, important content for all of you guys, as well as for all of our NCLEX preppers. So before we get started today, I have just a few different reminders for you guys. Go ahead and follow us at UWorld Nursing. Follow and share so you can make sure anyone in your nursing community and your social media community can benefit from this live. And keep letting us know what topics you want to see us cover. In the past few weeks, we've covered a lot of pediatric and maternal health topics. So keep dropping it in the chat, see what you guys want to see more of. We are here to help you, and let us know how we can best do that. A reminder that if you message us the word schedule, you will get a link to our events page, which is new and we're really happy with it. And if you message us free trial, you will also get a link to our UWorld 7-day free trial. We want to make sure we're getting you all plugged into our program. So whatever this looks like for you, let us know how we can help. Just so you know, this live will be on demand on both Facebook and YouTube for your future reference. And as always, drop your comments, your questions, your chats in those chat below, as well as your answers to our NCLEX style questions and the questions that we have peppered throughout today's lecture content. Nurse Jackie is moderating today, so stop by, and say hi to her. So let's go ahead and warm the chat up. Let us know, where's everyone joining from, who is joining us from the good old US of A, who is an international viewer. We've had a lot of international viewers from all over the world recently, and we love figuring out where everyone is joining us from. So don't be shy. Let us know in the chat where you're joining from. And without further ado, let's go ahead and get started today. So let's start with the overarching patho behind TBI, or traumatic brain injury. So TBI can be open or closed, meaning it can occur with or without a break to the skull. An open TBI can also be called like a penetrating brain injury. So TBIs can result in temporary or in permanent brain damage. So temporary brain damage would result in like an altered level of consciousness. This would typically resolve itself, and the client would eventually be able to resume a normal level of consciousness. In the cases of permanent brain damage, however, unfortunately, this will result in impairments such as cognitive, physical, as well as psychosocial impairments. So we have a great types of brain injury table. We're going to look at the different types of brain injuries, and this starts at concussion, which is the most mild TBI, and it kind of works its way down on that acuity spectrum. So as we get further down this table, these TBIs get more and more severe. So with concussion, we would consider this to be a mild traumatic brain injury, or a mild TBI. It can result from a mild blow or a bump to the head. I know many of you may have had concussions. I know I've had one. This produces a brief loss of consciousness, or it can also present with no loss of consciousness at all. Symptoms will include headache, dizziness, nausea, but the interesting thing here is a CT scan will not show injury to the brain. And these symptoms will typically resolve within 3 days. Let's move on to contusion, which is the further one down on this acuity spectrum. A contusion will be considered a bruise to the brain. It's a focal injury, meaning that it is localized, and symptoms will vary depending on the locations in the brain. We know that different areas of the brain control different things, like speech, like sight. So depending on where you have this contusion, that's really going to depend what your symptoms look like. Moving down, we're going to move on to diffuse axonal injury, or cerebral edema, you may hear this called. So the most common cause of a DAI, or a diffuse axonal injury, is going to be a high-speed vehicle collision, or high-speed motor collision. What it causes is the shearing of the brain's hemispheres. This happens from when the brain and the skull are whipped back and forth due to the crashing and the braking forces. So when we have a car accident, typically we have the force of the collision and then the whip back, which causes the brain to impact the skull as these forces are put upon the human body. You'll hear this called a coup counter coup. That's one of the, I forget the word that they call it, but it's it'll come to me later. It'll probably come to me after this live is over. But what it causes is the shearing of the brain's hemispheres and the shearing of those white matter tracts. And important to note here is that the white matter tracts connects the right and the left side of the brain together. So what we see here is diffuse brain swelling, and it can result, you can have a severe DAI that leads to a coma. Unfortunately, this is a very high mortality injury, and clients that do survive, a lot of them end up in a vegetative or a coma-like state. So to survive this is definitely a bit of a miracle, and when they do survive, a lot of clients do not have a great outcome. All right, moving down, we're going to move to skull fracture. So there's a couple different kinds of skull fractures. We can have linear, which occurs across the suture line of the skull. We can have depressed, which actually pushes down a piece of the skull inward, which will affect the brain. We can have comminuted, which is when the bone has shattered or fractured into smaller pieces. And all of these three different fracture types can cause injury to the underlying brain tissue, which is important to note. Alrighty, let's go ahead and move on to hematoma, which would be bleeding in the brain. And there are three different types that we're going to brush on today. The first being epidural, which is the most superficial, moving on to subdural, which is a little bit deeper. And the last is intracerebral, or bleeding deep within the brain tissue. So epidural and subdural are going to be the most common, and we're going to revisit this later in today's lecture because they have some similarities and some differences. I think when you're comparing and contrasting things, it's the easiest to remember them when you're looking at them side by side. So we will have a side-by-side image that you guys, again, are always welcome to screenshot. Take these with you. They're great resources for you to revisit in the future. Alrighty, so what are the clinical features of TBI? What is this going to look like in a clinical patient? So symptoms of TBI are typically due to the brain swelling that causes an increase in intracranial pressure, or ICP as we'll call it. So these symptoms include things like nausea, like vomiting. A hallmark sign of increased ICP is going to be actually projectile vomiting. This is a great symptom to memorize. This is a hallmark of increased ICP. So if you see projectile vomiting in a question or in an answer choice, go ahead and just have a TBI or increased ICP in the back of your head. Other symptoms include a worsening or severe headache, increased drowsiness, which can manifest as difficulty arousing these clients. They may present to be confused. We'll see behavioral changes like anger and irritability, motor problems like slurred speech, weakness in the extremities, and we can see sensory disturbances such as numbness in the extremities. A lot of these TBI clients will present with vision changes such as blurring and a sensitivity to lights, and pupillary changes are another important manifestation to pay attention to. The pupils can dilate, they can constrict, they can change in size, and these changes can be seen bilaterally or within both eyes, or unilaterally, meaning just on one eye. And also, increased ICP does increase the likelihood of seizure and seizure activity, so we would want to be enacting seizure precautions for these clients. So as far as diagnosing head injuries, the gold standard is going to be that CT scan. This is how we confirm brain injury. Alrighty, so let's go ahead and move on to skull fractures. So we have a great skull fracture image here, or basal skull fracture, and it's important to call this out separately because skull fractures present with some pretty unique features. So there are some unique clinical features to these clients who suffer from skull fractures and basal skull fractures. The first one we'll talk about is something called battle sign, which is bruising behind the ear in the mastoid portion of the skull, which is that area right behind the ear. You can feel it. You have a real bony section right there. Raccoon eyes are another thing that we see, which is exactly what it sounds like. It's those big bruised black eyes. They may be all the way around the eye. Sometimes they're just underneath, but these are a very noticeable symptom. And also leaking of the cerebrospinal fluid, or that CSF, from the nose and or the ears. To note, CSF on its own is a clear fluid. However, when there's a basal skull fracture or when there's trauma involved, that CSF can be tinted red or tinted pink because of the underlying blood that gets into it. But when we have this leaking from the nose, or when we have this leaking from the ears, the telltale sign is on a piece of clean gauze, it will leave a halo-like sign. I know that this skull fracture image does feature this. It shows you these raccoon eyes. It shows you that halo sign of the CSF on the gauze. Again, this is a great thing to screenshot and use for a future reference. I'm going to go ahead and put a sign out to the chat. But when we have a client who has a basal skull fracture or a suspected basal skull fracture, what kind of tube do we avoid using in these clients? So what kind of tube, if you see an order for it, you're going to be calling the provider and clarifying what tube would be contraindicated here. Alrighty, I'm going to give you some time to go ahead and drop your answers in the chat. Again, we are asking what tube would be contraindicated in a client with a basal skull fracture. In the meantime, a reminder, we have started putting out nurse life videos. These differ from a lot of the content that you've seen here previously because it's not lecture-based, it's not specifically NCLEX style question-based. It's going to be answering the questions and hitting a lot of points that I feel like are not talked about enough in the nursing journey. Things like what to expect on your NCLEX day, what to bring to your NCLEX, how to survive an accelerated nursing program, just like tips and tricks that the seasoned nurses of UWorld have compiled in our practice that we want to share with you to make sure that you are ready and prepped and have all the important information that you need. Alrighty, I'm going to go ahead and check the chat again, see what we're thinking, and you guys, per usual, spot on. NG tube, NG, NGT, you guys got it. So that nasogastric tube is what's going to be contraindicated in this case. So why is this? A basal skull fracture. We have a fracture to our skull bones, and severe trauma to those facial bones too. So the nose and the brain are very closer together, and part of those skull bones actually separate kind of the facial bones with the cavity for the brain. So if this bone integrity is compromised and potentially fractured, the risk that we run is when you put an NG tube in, as opposed to that NG tube intubating the nose and the esophagus as it is supposed to do, it can actually go through that compromised bone and intubate the brain, which we definitely do not want to do. We don't want to be putting an NG tube with suction or whatever it is into the brain directly. That's very, very dangerous. So in a client with a basal skull fracture, we would not be using an NG tube. Okie doke. Y'all did so great on that. Proud of you. Way to go. We're starting this week off strong. Let's go ahead and move on to hematoma. So epidural and subdural hematoma. As promised, we're going to touch on this now. I know I mentioned it briefly at the beginning of this lecture, but what's the difference here? So epidural is going to be more superficial. Again, this is the bleeding in the brain. So blood is going to accumulate between the dura mater and the skull in the epidural hematoma. The cause of an epidural hematoma is arterial bleeding. And because it's from an artery, bleeding here typically comes on more quickly, making an epidural hematoma typically presents very acute, very quickly, and that's a good way to remember it. So the acute quick onset here leads to rapid hematoma expansion, which results in an increased ICP, again, that increased intracranial pressure. You're going to keep hearing this today, and that can contribute to neurological decompensation. So here's some of the signs and symptoms we can see is a quick onset or an acute change in level of consciousness, headache, nausea, and vomiting. Again, an increased ICP, a hallmark sign is projectile vomiting. And this is an emergency. We need to act fast. Again, it's arterial bleeding, so it has a proclivity to come on very quickly, to get even worse very quickly. And typically an epidural hematoma will require surgical evacuation. Alrighty, let's go ahead and look at subdural hematoma. What's the difference here? So subdural hematoma, a little bit deeper here. This is the blood that accumulates between the skull and the brain. It's caused by venous tearing and bleeding, and an expanding hematoma leads to increased ICP, and it can lead to brain compression as a result of this. It can be acute if lots of the vessels are involved. However, it can also be slower, subacute, and even be considered chronic if only a few vessels are affected, if only a few vessels are torn and bleeding. So again, this is a great reference for you guys. Subdural versus epidural hematoma. Go ahead and screenshot this. I'll give you a second to do it. Because I think this is a really great way to memorize the difference between a subdural and an epidural hematoma. Alrighty, so let's move on to nursing interventions. What are we going to do for these neurological clients? How are we going to take the best possible care of them we can as nurses? So an important thing here for any neurological setting, any neuro patient, the Glasgow Coma Scale is going to be kind of like your bread and butter. So this is used to determine symptom severity using verbal responses, motor responses, and eye-opening abilities. Important to note, it's a scale that goes up to 15. The lower the number, the less function, the worse off this client is, and the higher up the number, the better they're doing. So 8 or below on the Glasgow Coma Scale, or a GCS score as we'll call it, would be considered to be coma-like states. So a mild TBI is going to be 13 to 15 as a GCS score. A moderate TBI will be 9 to 12. And a severe TBI will be at or equal to, or less than, 8, which again, that indicates there's not a lot of function going on, and this client most likely has a decreased respiratory drive and will need some kind of intubation. Whenever we have a client that initially presents with a neurological issue, it's always best practice to assume a neck injury before we rule it out. So we would stabilize the cervical spine. We would keep clients in a hard collar in order to do this, to keep that cervical spine midline and stabilized. We're going to be continuously monitoring these clients for increased ICP. Again, a hallmark sign of this is that projectile vomiting. We're going to be giving them supplementary oxygen as well. We're also going to be making sure they have a good, reliable IV access. We want to ensure 2 large bore IVs, and clients in a neurological setting will typically receive 0.9% sodium chloride as their fluid of choice. We're going to maintain normothermia because these clients, sometimes with brain injuries, their body is not able to do this on their own. So this may look like extra blankets, warming blankets. We may be giving them warmed IV fluids. Again, we brushed on this earlier, but intubation may be required for clients with a GCS score at or lower than 8, and they're going to need mechanical ventilation to help supplement that decreased respiratory drive. As nurses, we're going to be consistently assessing the pupils and that pupillary response. So we're checking the size of the pupils. Are they really dilated? Are they really constricted? The reactivity, like to light, to movement. And we're going to be assessing, is this pupillary change a unilateral change, so only affecting one side, or is it a bilateral change affecting both sides? We're also going to be checking for rhinorrhea and ear drainage because, again, these are the places that CSF is going to be leaking from our nose and from our ears. And an additional thing to do is to check for any scalp wounds, any open skull wounds, so we can ensure, is this skull fracture one that's just to the bone, or is it a penetrating injury? For these clients, as we track their progress, as we hopefully see them get better and better, CT scans are going to be done serially, to check what's the status of the client's condition? Are they getting better? Are they decompensating? And depending on the results, these clients may require surgery. So a common type of surgical intervention we'll see is the placement of an intraventricular catheter, or an IVC. And this is maybe placed just to continuously monitor that ICP. A lot of times you see continuous monitors, like arterial lines, placed to monitor clients' blood pressures, which I know we talked about that in the live recently. But these IVCs are placed to continuously manage this ICP, to see, if it's getting higher, if we need to be doing surgical intervention, and prevent any further brain damage from that increased ICP. So positioning, these clients are going to be with the head of the bed elevated at a 15 to 30 degree angle. And the exception here is going to be any spinal injuries. In that case, we would want them to be flat. The head should always remain midline to avoid neck extension and flexion. We will be log rolling these clients, so keeping that cervical spine stabilized. But again, elevated at 15 to 30 degrees, which will also help to decrease that ICP. Alrighty, so medications here. The point originally in these neurological clients is we really want to make sure we're controlling that ICP. So a lot of our medications are going to be geared towards that. I'm going to put a question out to the chat. What is a common diuretic medication used to decrease ICP? It's used very often in a neurological setting. It's a common diuretic. It's an osmotic diuretic. I'll give you a little hint. So go ahead and drop your answers in the chat. Let me know what you're thinking. And this is kind of, I feel like whenever you start your neurological chapters or you're studying it in nursing school, I feel like this is like the first thing that the lecturer is going to brush on. But I know you guys can get it. You've done so well. Alrighty, let's see here. And you guys are doing phenomenal. Yes, you nailed it. Mannitol. So that is the osmotic diuretic given to decrease ICP, or decrease that intracranial pressure. How this works is that it pulls fluid from the brain into that systemic circulation and then aids the body to diurese it, or get rid of it. And again, when we pull fluid to decrease that fluid volume in the brain, it will in turn decrease the pressure. Alrighty, so important to note, just a little nursing key here, mannitol can crystallize, especially at low temperatures. So we're always making sure that when we have IV mannitol, we are keeping it at the appropriate temperature that pharmacy is going to dictate. They're going to tell you what you need to keep it at. And if we're administering it, we're always going to check beforehand to see, is it crystallized? In that case, we would not want to give it. Alrighty, so we also want to make sure as nurses we are monitoring and preventing any complications here. So we're going to be monitoring for seizure and seizure-like activity. Both brain injury and an increased ICP can lead to seizure. A key sign of this is going to be hyperreflexivity or those really, really brisk DTRs. We also want to make sure we're preventing fever as well as infection. And the reason why we want to do this is because fever and infection can increase the body's metabolic rate, which can in turn also increase ICP. The name of the game in a neurological setting is keeping that ICP down, making sure it's not increased. So we would be preventing fever, making sure we are keeping them normothermic, doing frequent vital checks to check their temperature, and also doing things like hand washing, proper hand hygiene, educating their visitors on the need to keep a cleanly area so we are preventing infection. Alrighty, another potential complication of a neurological injury is going to be a DVT or a deep vein thrombosis because these clients are pretty sedentary. So we want to make sure we have an order for SCDs or those sequential compression devices. These clients may be on a chemical prophylaxis for DVT like a heparin or a Lovenox, but very important to remember that DVTs are dangerous and we want to make sure that we are positioning these clients frequently and we are applying those SCDs and making sure there's an order for your SCDs too. And also important to note that stress ulcers can develop from the trauma of this traumatic brain injury. Alrighty, so moving on, our last topic to brush on is going to be craniectomy and the post-op craniectomy care. So what is a craniectomy? We again have a great resource for you guys. Go ahead and screenshot this, take it with you. A craniectomy is when we remove a piece of the skull in an effort to decrease the ICP. So again, another ICP point. You guys are probably sick of it by this point, but the surgeon will take this piece of skull out and then close the skin and muscle layers over the area without that original piece of bone. Now this helps because when the brain expands a little because of this ICP, it's not going to be pushing up against that skull, causing brain compression and increased ICP. However, without that piece of skull, this does leave the client very vulnerable to injury. We don't have that protective bone layer. Because of this, the client should never be positioned on their operative side. They should always be positioned on their back or on their non-operative side. But again, there's nothing to cushion that brain, so we're not positioning on the operative side where the site of the craniectomy occurred. We are closely monitoring their drain output. We're also going to monitor their head dressings when the actual surgical site was, and keep a close eye out for signs of hemorrhage, which would be excessive bleeding, and sign of infection like a purulent drainage, a yellow or a green drainage. Alrighty, so that concludes our lecture content for the day. You guys did so well. I think everybody answered my questions completely 100% correct, which is amazing. So let's go ahead and move on to our first question today, which is going to be an intervene question. So the nurse is observing a staff member caring for a client who has sustained a traumatic brain injury without cervical spinal injury. Important to note. So the nurse should intervene if the staff member is observed. Option 1, turning the client using the log roll technique to remove soiled linen. Option 2, checking the client's pupils for size in reaction to light. Option 3, monitoring the client's gag and cough reflexes. And 4, placing client in the Trendelenburg position. Alright, I'll give you guys some time. Go ahead and drop your answers in the chat. And you're doing so well. I'm sure that you're going to keep this up today. A reminder that we have that events page live now. We're really excited about it. What you can do is there's a link here in the chat. If you want to look through, we have it there. You can also DM us events and you'll get a link to our event page. But here we have the topics that we're going to be doing in our live sessions for the next 3 weeks. So you can tune in, see, what's important to you, what you want to brush up on, attend as many or as few as you want to. And you can also plug in your name and email. So you actually get an email straight to your inbox that tells you each week what we're going to be covering. The events page also is a great kind of home base for a link to our 7-day free trial, link to important blog posts. But this is a really, really great resource, and I hope you all take advantage of it. So make sure you look for that link in our chat. Alrighty, so let me go ahead and see what you guys are thinking in our chat today. And again, I see almost entirely correct options, a few ones that are a little bit off, but mostly you guys got it Spot on. Our correct answer is going to be option 4, placing the client in Trendelenburg position. So important to note, this is a negatively minded question. So the nurse should intervene. We intervene when we observe a staff member doing something incorrect. And in this case, the incorrect thing would be to place the client in the Trendelenburg position, which is why this is the correct answer. So in Trendelenburg, remember what this is. It's the foot of the bed is elevated, so the feet are high, and the head of the bed is lower, so the head is low. This is going to encourage the movement of fluid, of volume, down towards the head. In a neurological client, we are preventing increased ICP, and more volume towards the head is going to do exactly that, increase the ICP. This is what we're trying to avoid. We're also always wanting to avoid extreme flexion or extension of the neck. We are keeping the head in a midline in a neutral position. And instead of Trendelenburg, we are keeping the head of the bed at 15 to 30 degrees. If there is not a cervical spine injury, which this question does mention, there's no cervical spine injury. Alrighty, so why are the other options incorrect? So again, it's intervenes. We're intervening for the incorrect option. Turning the client using the log roll technique to remove soiled linen. Log roll is great for these neurological clients. It keeps the entire body in a straight line and just rolls them over to the side. This keeps that head midline in a neutral position, which again is what we want to do. Alrighty, and then checking the pupils for size and reaction to light, another consistent assessment we should be doing as nurses on neurological patients. Pupils are a great indicator of brain health, of where they stand neurologically. And lastly, monitoring the client's gag and cough reflexes is a way that we prevent aspiration. Okay, great job on that way. You guys did so well. Let's move on to our last question of the day. The nurses attended a staff education program about seizure precautions. Which of the following statements by the nurse would indicate a correct understanding of the program? Select all that apply. Alrighty, option 1, I should ensure there is suction equipment in the client's room. Option 2, I will document the duration of and the behavior observed during a client seizure. Option 3, I should raise the head of the client's bed during a seizure to protect the client's airway. And number 5, I should insert a tongue depressor in the client's mouth during a seizure to prevent injury to the tongue. Alrighty, so remember it's a select all that apply question, so go ahead and drop your answers in the chat. Alrighty, and we're doing so well today. I know you will continue this. If you have not followed us, make sure you follow us at UWorld Nursing on your preferred social channel. Wherever you're tuning in from today, go ahead and follow. We want to make sure that you don't miss out any of these great resources we have going forward. Again, we do lecture-based content on Tuesdays at 12 p.m. Central Standard Time, and we follow that up with 2 question drills at 3 p.m. Central Standard Time on Wednesdays and Thursdays. Nurse Jackie will be doing those this week, so make sure you tune in for those. Follow us on social just to make sure you're not missing out on any of these great resources that we plan for you guys. Alrighty, I'm going to go ahead and drop back into the chat, and I see a lot of great answers. You guys definitely got the gist of this. I see lots of 1s, 2s, and 4s, which are all of our correct answers. So way to go. Let's go over this real quickly. So for option 1, I should ensure there is suction equipment in the client's room. Again, we are talking about seizure precautions here. And again, these TBI patients, these neurological patients, are at an increased risk for seizure, so we would be enacting seizure precautions for them. So suction, we want to make sure that suction not only is available in the room, it's already set up and ready to go. That way, if we need it in a pinch, we're not having to go back, get all the parts, connect everything, make sure it works. It's already done and ready to go. This also makes it easy for us to clear the client's airway if they were to have a seizure, to prevent aspirations from saliva and blood post-ictally. So suction, always a thing in seizure precautions. This is correct. Option 2, I will document the duration of and the behavior observed during a client seizure. We always want to document how long the seizure is. It should be documented. It should be well charted. And the behavior as well, so we know, is this a tonic-clonic seizure? Is it a grand mal seizure? What kind of seizure was it? We're always documenting this, and the timing is so important. We want to know how long they were seizing for. Option 4, I will activate the call light to request assistance if a client is experiencing a seizure. Another thing we would want to do, if a client is seizing, under no circumstance do we want to leave them alone. So we wouldn't run out in the hallway and grab a coworker. We would instead press the call assistance button so that help comes to us as opposed to us having to go to the help. So always stay by the client side. So again, 1, 2, and 4 are our correct options. In 3, we would not be raising the head of the bed. We would typically be keeping it flat and putting the client on their side. We also want to make sure we're padding those side rails. And lastly, 5, I should insert a tongue depressor in the client's mouth during a seizure to prevent injury to the tongue. This is incorrect. We do not want to insert anything into the client's mouth during a seizure. This is a huge risk for injury. So no tongue depressor. I think that's an antiquated, kind of outdated intervention. Nothing in the client's mouth during a seizure. Alrighty, so great job on that one. I think you guys got it almost all correct options. So you did so well today. Way to go. A reminder, on Wednesday, we're going to be covering select all that apply questions. So this last question was a select all that apply question. If you struggle with those, if you need more help, make sure you join us for that tomorrow at 3 p.m. Central Standard Time. As well as on Thursday, we'll be back with a hematology-based question drill. Alrighty, so for our UWorld users who have already purchased this product, we have a quick video to show you how to navigate on our QBank to more neurological questions. It shows you the right subject and system to select in order to get a practice test that populates with neurological based questions. They won't be specifically TBI, but they will be about all things neuro, all things seizure precautions. TBI will be included. ICP questions will be included. So if you want to brush up and test your knowledge, make sure you select the subjects and systems that are included in this video. In closing, thank y'all so much for staying tuned today. You did so well. Neurological concepts can be really complex, and mastering the content in today's lecture requires some dedicated study time, but you all did so great today. Way to go. A reminder that all of these lives are still available on demand on Facebook and YouTube after we're done here today, so you can always drop back in and revisit it. A reminder to join us again tomorrow at 3 p.m. Central Standard Time for that question drill. And thank y'all so much for joining. I will see you guys next time.